Welcome everybody. My name is Dr. Elizabeth Kolsky, and I am the director of the Albert LePage Center for History and the Public Interest at Villanova University, where I am also an associate professor of history. And today is the 18th and final event in our year-long series on decolonizing history. We've been at this since September. And we are very, very happy to have Dr. Sharrelle Barber culminate this series for us. For those of you who have been with us intermittently, I do want to remind you that all of the events, or almost all of them, are posted on our YouTube channel, which I will put in the chat, so that if you have seen some of these events, participate in some, but not all, you have an opportunity to watch them. Today,
I was just checking, when are you going to start to have people?
Just a quick reminder to put your microphones on mute. The event for today, Dr. Sharrelle Barber is going to speak with us for about 30 to 40 minutes, leaving about 20 minutes for Q&A at the end. As a center engaged in history and the public interest, we really rely on public engagement. So we look forward to hearing your questions. You're welcome to pose questions in the chat or just hang on to them, and you can pose them live at the end of her presentation. So without further ado, I will introduce our speaker. Our speaker today is Dr. Sharrelle Barber, who is an assistant professor in the Department of Epidemiology and Biostatistics and the Urban Health Collaborative at the Drexel University Dornsife School of Public Health. She is also, as I understand it, soon to be director of Drexel University's new Center on Racism in Health. Dr. Barber received a Doctor of Science degree in social epidemiology from Harvard, a master's in public health from UNC Chapel Hill, and a Bachelor of Science in Biology from Bennett College. Her research focuses on the intersection of place, race, and health. Her work examines the role of structural racism in shaping health inequities among Black folks in the Southern United States and Brazil. She has authored multiple peer-reviewed articles in many leading journals, and she herself was recently profiled in The Lancet, which is a very prominent British journal, which I'll put that profile in the chat. During the COVID-19 pandemic, Dr. Barber has secured funding to examine the impact of racism and segregation on health inequities in COVID-19 in Philadelphia. She is also part of a research collaboration between Drexel's Urban Health Collaborative and the Big Cities Health Coalition, examining COVID-19 inequities in the 30 largest cities in the United States. As a social epidemiologist and scholar activist, Dr. Barber is committing to using her scholarship to make the invisible visible, to mobilize data for action, and to contribute to the transnational dialogue around racism and health inequities. It is my great pleasure to introduce to you Dr. Sharrelle Barber.
Thank you so much, Dr. Kolsky, for that introduction and for the invitation to be with you all today. It's really, I'm really honored to be with you all this afternoon. And so let me go ahead and share my screen with you all. And so I thought that I really appreciate, oops, that's not the first slide, sorry. I really appreciated the title for this series, but also the title for this particular talk, as I think it's a very important framing of the COVID-19 pandemic, as we've now been in it for a year. And so what I'm going to do is it also allowed me to do some reflecting on what it means to decolonize COVID-19. And so I'm going to talk today about thinking about this in three different ways. One, how we decolonize the narrative around COVID-19. Two, how we decolonize the knowledge production around COVID-19. And then finally, how we decolonize our actions, both in the midst of the pandemic and beyond, and really centering the role of racism as well as resistance during this pandemic. I'd also like to do a land acknowledgement. I do my work and am supported by the work that I do in Philadelphia and Drexel. And so just want to acknowledge that the land on which we gather are the ancestral lands of the Lenape people whose presence and resilience, and I would say resistance in Pennsylvania continues to this day. We take this opportunity to honor the original caretakers of this land and recognize that the histories of land theft, violence, erasure, and oppression that has us here. I also, in many of these, I've done dozens of lectures over the course of the year around COVID-19, around the inequities. And one of the things that I also like to acknowledge is that, you know, we have surpassed 3 million deaths globally in the pandemic, 3 million deaths. And here in the United States, we are approaching 600,000 deaths. I just looked at the numbers this morning, and those that we know about are 568,000. We approached that 500,000 mark earlier this year. And I do think it's important that as we're in this pandemic and as we talk about the pandemic, that we do the kind of collective mourning that's necessary, because I think it honors the very human nature of this pandemic. This pandemic has taken lives. It's taken mothers and daughters and fathers and brothers and sisters and uncles and aunts and grandparents away from us. And as a social epidemiologist, whose part of my job description is to count death, I can't lose sight of the humanity of that, right? And the holes that have been left. And what this teaches us about the work that we need to do in terms of securing better health for all of us. And so I want to just pause and honor that in this moment. And then by way of introducing this lecture, I actually want to read an excerpt from a commentary that I was asked to write by the journal Epidemiology. As Dr. Polsky mentioned, I'm a social epidemiologist, and for many of us, it's been a year of really reflecting on what our field is and how we should be. And I took the time to pen this. This was, I wrote this back in September of 2020. It was released at the onset of this year, 2021. But we were just asked very simply to reflect on what 2020 meant to us. And so here is part of that reflection. On March 13, 2020, at approximately 12:40 a.m., police officers in Louisville, Kentucky executed a no-knock warrant in a botched drug raid that ultimately led to the horrific murder of Breonna Taylor, a 26-year-old emergency room technician and first responder who committed herself daily to saving lives. On the same day, the Trump administration declared the COVID-19 pandemic a national emergency after months of irresponsibly downplaying its seriousness. Within a few weeks, a virus that was first viewed as a great equalizer began a deadly trajectory, disproportionately impacting Black Americans and other marginalized racial groups. By mid-September, 20% of the COVID-19 pandemic had claimed the lives of 40,000 Black Americans, accounting for 20% of COVID-19 deaths. And on September 23rd, 2020, after months of local, national, and global protests demanding that we say her name, the police officers responsible for Breonna Taylor's untimely and unjust death walked away unscathed by a system indifferent to Black lives, but fully committed to protecting its own at all cost. The confluence of these events, an act of state-sanctioned violence against a young Black woman with no rendering of justice, and a global pandemic wreaking havoc on Black communities across the country and around the world, is the backdrop against which I must situate my reflections on what it has meant to be Black, a woman, and a social epidemiologist in 2020. The range of emotions have been wide, from crushing heartbreak to seething rage to physical and emotional exhaustion. As I have joined in collective mourning over the unjust and avoidable deaths we have all had to bear witness to in this moment, and also engaged in collective scholarship and activism in an attempt to document and disrupt this reality. Suffice it to say that 2020 has been a gut-wrenching reminder that racism in all of its forms is deadly, bringing into sharp focus what so many scholars have been saying for so many years. It has been a year of hyper-visibility in a field that has more often than not sidelined and sometimes silenced these ideas, deeming them marginal at best explanations of the truncated lives and the too often violent deaths that have plagued Blacks in this country for over 400 years. And so I read this excerpt because I think it really encapsulates so much of what I think it means to decolonize COVID-19 and our understanding of the racial inequities that have arisen. And so, like I said, myself, along with many colleagues, saw the COVID-19 pandemic as it emerged and the racial inequities that emerged in late March as a byproduct of structural racism. However, we recognize that the mainstream narrative, even coming from some of our top officials in the past administration, did not see it that way. And so it was going to be really critical in this moment to shape a narrative that looks and points to the longstanding legacy of racism and white supremacy in this country, as opposed to a narrative that demonizes communities, blames communities for the inequities that we see. And this was a quote from the Surgeon General back in 2020, early 2020, when he said, "Avoid alcohol, tobacco, and drugs, and call your friends and family. Check in on your mother. She wants to hear from you right now." And he goes on to say, "We need you to understand, especially in communities of color, we need you to step up and help stop the spread so that we can protect those who are most vulnerable." Again, a very blame the victim narrative, and also putting the onus or the responsibility of action on communities who have been plagued by racism in this country for so many years. And so early on in the pandemic, colleagues and I from around the country penned one of the first op-eds entitled "Racism in the Time of COVID-19" that really began to say that what we're seeing in terms of the pandemic, in terms of the racial inequities, particularly what we were seeing among Black Americans, was one, it was predictable, but it was, again, shaped by racism. And while COVID-19 is, we said that while COVID-19 is indiscriminate in its transmission, its propagation within a society steeped in structural racism will undoubtedly, as we're already beginning to see, lead to disproportionate impacts among marginalized racial groups in this country. And we said this, and we're writing this particular piece commentary before there was data that emerged. And we had several clues that could, that really for us, we knew that these were going to emerge despite the dominant narrative. One, the clue that among leading causes of death, Black Americans in particular have always died, one, at higher rates, but also at younger ages than whites. And this is data that goes back all the way to 1900. And again, the racial inequities have been persistent and consistent across this time period. We also know that of the 15 leading causes of death caused by death, including cardiovascular disease, stroke, diabetes, and others, Black Americans die at higher rates of 9 of these leading causes of death. Again, this pattern is consistent, persistent, and we knew that COVID-19 would be no different. We also recognized, again, that racism is this country's underlying pre-existing condition, and that any understanding of racial inequities had to begin with the very foundation or the pillars upon which this country was built. That is the forced expulsion and genocide of Indigenous people that led to their removal and erasure from so many parts of this country. But also, it is also built upon the legacy of enslavement that literally extracted millions of West and Central Africans to this country into generations of forced labor. And if you think about the time since 1619 or slavery, that was for Black Americans, that's been the majority of our time in this country. And even post-slavery, we had Jim Crow and segregation and other ways of keeping Blacks, quote unquote, in their place and subjugating them to the conditions that are not conducive to health. And even since the Civil Rights Movement, if you look beyond 1964, there have been laws and practices and policies that could have continued to harm the health and well-being of Black communities. And so therefore, any understanding of health, any understanding of how health inequities must begin with this history. And Dr. Kamara Jones, I think, has a very appropriate definition of racism. Dr. Kamara Jones is an epidemiologist. She's been doing work on racism and health for over 30 years, and is also a former president of the American Public Health Association. And to, again, focus our attention on the system, she defines it as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, because we know race is a social construct. And it unfairly disadvantages some individuals and communities. It unfairly advantages other individuals and communities, and it saps the strength of the whole society through the waste of human resources. And this has shown up during this pandemic, as we have seen Black American communities and Indigenous communities and Latinx communities and other marginalized groups in this country face a disproportionate burden of the pandemic, but we also know that that has been because their white individuals have had unfair advantages that have protected them during this pandemic. And the final point, this saps the strength of the whole society, is so critical because we know that the pandemic, as long as there are inequities, and long as there is the COVID-19 in any community, none of us are safe. And so this pandemic has literally exploited the deep fissures, the deep inequities that have been caused by generations of racism and white supremacy in this country. And to kind of just visualize that, myself and colleagues have put together a conceptual model that moves us away from just simply talking about the quote unquote social determinants of health, to really thinking even further upstream to the systems and structures that are, one, interlocking, that two, act synergistically, and have done so to amplify differential exposure, transmission, and differential susceptibility to severe disease and death. And so we can't understand this pandemic without understanding racial capitalism, segregation and dispossession, our exclusionary immigration system, mass incarceration and detention, extractive and polluting industries, as well as our tiered healthcare system. All of these have come together and combined to create what we have seen in this pandemic. And this is the narrative that we have to continue to put forth, even as we think about what our next steps in this phase of the pandemic, because one of the things I think that's really critical to recognize is that it's not over. And especially for the communities that have been hardest hit, we still need to be keeping an eye on deaths and cases in these communities, because these same structures are going to create even worse racial inequities as we begin to quote unquote emerge out of the pandemic. And so here are the numbers that I'm sure many of you are aware of in terms of cases, hospitalizations, and deaths for Black Americans, for Hispanics, for Indigenous populations as well. But one piece of data that I think is also very alarming is what we have seen in terms of life expectancy declines. Now, all racial groups in the United States have experienced life expectancy declines according to data from CDC. But Black men in particular lost 3 years of life in this past year during the pandemic. And again, I think that's so critical to recognize that while the pandemic hit us all, it was disproportionately felt by certain communities, and the loss of life, not only in terms of death, but actual life expectancy is also being, we're also seeing that. And again, Black men lost 3 years of life during the last year. So in my work, I call what we see with COVID-19 and so many other outcomes is really what Dr. Nancy Krieger, she has this concept called embodiment, but it's the embodiment or embodied racism. And I think Ta-Nehisi Coates does a great job of describing that. And he wasn't necessarily talking about health, but I think this quote from Between the World and Me really gets at it. He says, but all our phrasing, race relations, racial chasm, racial justice, racial profiling, white privilege, even white supremacy, serves to obscure that racism is a visceral experience, that it dislodges brains, blocks airways, rips muscle, extracts organs, cracks bones, breaks teeth. You must never look away from this. You must always remember that the sociology, the history, the economics, the graphs, the charts, the regressions all land with great violence upon the body. And we see this in instances of police brutality, like with George Floyd, Breonna Taylor, and so many others. But again, the very insidious, more subtle ways racism operates is also important to recognize. And it really literally is how Black Americans and other marginalized racial groups become so susceptible to disease. And so in my work, I have focused, part of the narrative shift has really been thinking about what are some of those structures and systems. And I think that racial residential segregation is really fundamental to our understanding of racial inequities. I'm sure you've heard the narrative that your zip code is more important than your genetic code in determining health, and that's really true. And for Black Americans in particular who have experienced racial residential segregation persistently, it's really critical in that understanding. And so, you know, we begin historically with the practice of redlining and the literal disinvestment that has happened over decades in these communities. This segregation, and one thing I'll say about the segregation that, you know, that redlining did not create the segregation, but it did codify the segregation and literally created maps, redlining maps for cities across the country. This codification was then upheld by things like restrictive covenants that restricted the residential mobility, particularly for Black Americans. And there's widespread data that shows the loss of wealth and the loss of residential mobility that Blacks have experienced over the last almost century. And because our country is such that it upholds these systems and structures, not only through policies, but also through violence, we know that segregation was also upheld by a lot of racial violence and terror. The picture that I am showing here is a picture from the 1950s in Cicero, Illinois, right outside of Chicago, when a working class Black family attempted to move from the crowded, unsanitary conditions of Chicago into better living conditions that would be more conducive to their health and well-being. And a mob of literally 4,000 white individuals came, burned their belongings, and this all while police were standing by. And so we've talked a lot in this last year about protests, about the violence of protest and the destruction of property, when literally violence is the way this country has responded and maintained the racist systems and structures that exist. And so any talk about violence must begin with the violence, the very real violence of racism and white supremacy. So we get to, from 1968, we have the Civil Rights Movement, and then on April 11th in 1968, we get the signing of the Fair Housing Act. One of the things that I like to point out about this particular act is that it was signed literally 1 week after the assassination of Dr. Martin Luther King Jr. This is important for a number of reasons. One, the act or discrimination in housing have been brought to Congress and for movement, and we did not get movement on it until this assassination. And so many of the social justice and civil rights advancements that we've had in this country have been paid for in blood. And we can't ignore that and recognize that our push towards equity, our push towards justice has literally been paid for in that way. But despite 1968 and the Fair Housing Act, we're still very separate and unequal, and racial residential segregation continues to persist, which is why I think it's, again, a fundamental driver of racial health inequities. Now, I set all of this up because it's so important to be very particular and very explicit about the ways, the mechanisms that racism operates to produce these racial inequities. Again, how we frame the narrative around racial inequities, how we quote unquote decolonize that narrative is so critical because it not only helps us to understand these inequities, but also to address them. And so a couple of other points I'll make is that when we think about environmental racism, Philadelphia is a prime example of this. The community of South Philadelphia was plagued by the refinery for many, many years, higher rates of asthma and cancer. And the interesting part about the refinery is that in the 1930s, when the redlining map was created for Philadelphia, the refinery already existed. So the area around the refinery was actually redlined. However, in the 1940s, when local government decided to create low income, mostly housing for Blacks in the city, that's where they decided to put the public housing, right? So they basically were like, well, the refinery is there and it might cause some problems, but it's okay to put Black folks there, right? Concentrate Black folks literally near a place that could cause so much death and destruction. And we've seen that over the years that in South Philly, the higher rates. We've also seen in that same community activists, speaking out against the refinery, speaking out against what it's doing. And unfortunately, that outcry falling on deaf ears in many ways. But again, fighting nonetheless, and really literally fighting for their lives. We talked a lot in this pandemic also about how mass incarceration and police brutality have kind of also, been amplified in this moment. And I think it has another thread that links it to the COVID-19 very specifically, and that is that our investment in law enforcement and police has literally been at the expense of investing in things like affordable, stable housing and education and jobs and other things like that. And so there's been billions of dollars literally invested into the militarization of our police forces around the country, while at the same time, there has been a disinvestment in the things that would actually be conducive to life. And this picture is a picture that I have used since last June. It was a picture during the protests after George Floyd was brutally lynched and murdered in May. And it just hit me, it struck me that our response to the protests, these were peaceful protests here in Philadelphia. We literally were able to mobilize within days the National Guard to quote unquote quail the protests. However, it took us months and we're still catching up to muster up a response to the COVID-19 pandemic in the hardest hit communities in Philadelphia, right? And again, this was just a reminder that we put our resources where we want to, and we in so many ways display an investment in death as opposed to an investment in life. And so all of that background, this idea that we need to frame this narrative around COVID-19 that has a lens and a lens through structural racism led to a project that I led with colleagues at Drexel entitled COVID in Context, and really wanting to then, once we decolonize the narrative, decolonize the knowledge production and data around COVID-19 here in the city of Philadelphia. And so this is our really powerful COVID in Context team. There's social epidemiologists on this page, spatial epidemiologists, we have students, and we also had some individuals from the community to help us with some storytelling, because we wanted to do two things. One, document the racial inequities and COVID-19 by segregation in the city of Philadelphia. But we also wanted to amplify the real lived experiences of the individuals living in some of the hardest hit communities in Philadelphia. And so we pulled this really powerful team together and have been working over the course of the last year really to show the data in a way that's real, that delineates these mechanisms and also amplifies voice. And so we started again with history and a historical perspective, thinking about how redlining from the 1930s has led to some persistent racial residential segregation and conditions within communities that were made transmission of COVID-19 and deaths from COVID-19 more likely. And we saw a through line between areas of North Philadelphia as well as areas of West Philadelphia, which we know now have some of the highest cases and highest deaths due to COVID-19. We also wanted to compare cases initially, this is data from early in the pandemic, so between March and mid-May, compare cases between the most segregated zip codes in Philadelphia and the least segregated zip codes, and found that the rates were 2 times higher in the most segregated zip codes compared to the least segregated zip codes. And the time period we chose was very important. It was that time period when we knew that when there was a lockdown in the city. So there wasn't a lot of movement except for essential workers who were literally being forced to work in these conditions, not being protected from exposure, and circling in and out of these communities, right? Which then amplified risk in that setting. We've updated this analysis since then and to January, and we've seen that cases, the inequities in cases have declined some, but the death rates are much higher, about 70% higher in the most segregated zip codes in Philadelphia compared to the least segregated zip codes. And so I said, so part of the project was documenting and looking at these racial inequities and really showing where there were inequities in the city. The other part of this project was amplifying. Again, how do we decolonize data knowledge production so there's not just experts, quote unquote experts, but also amplifying the lived experiences of communities. And so we held a series of community conversations and we had one-on-one conversations with individuals within West Philadelphia and North Philadelphia. Some of the community groups that we talked to were part of the West Philadelphia Promise Zone. We also talked to a group of young adults between the ages of 18 and 25 for the Village of Arts and Humanities, and some critical community leaders and folks who have been on the ground since the pandemic, really advocating for the kinds of amenities and things to get people through the pandemic. And so I'm going to actually share the video. It's a 5-minute video of what we have produced. And this is actually going to be a part of a series that we disseminate over the course of the next few months. Let me actually share. Okay. Sorry about that. So that's part of COVID in context. And like I said, there was just so much rich insight that we got about how the pandemic is really impacting certain communities. And so I'll just move on relatively quickly in essence of time for questions. But just, again, part of decolonizing COVID is actually going to communities and seeing what they have experienced and also what kind of action that they deem is necessary. I'll also just point to work of colleagues in Brazil who've been, again, I think a part of decolonizing COVID is also to expand our understanding of what the COVID pandemic looks like beyond the borders of the US, and particularly what racial inequities look like in other racialized contexts. So I do work in Brazil, and racism has, again, operated there in very similar ways to influence the pandemic. The final thing that I'll say is that, so we decolonize the narrative, we decolonize knowledge production, but it's also important to decolonize our response. And so there are definitely public health measures that have been taken and looked at in terms of what needs to be done. But if we're really going to think about how we reimagine our world, our city, our country post COVID-19, we need to be looking to some of the bold solutions that folks are, particularly social movements, have been putting out that are necessary because we can't go back to normal. So, maybe a start perhaps is declaring racism a public health crisis, like so many other cities have done across the country, but not just stopping there, actually doing the work, putting forth the public policies that are necessary to both dismantle the systems that exist, but also reimagine and rebuild systems that are more equitable. Reparations as a public health priority is something that has been talked about too, in terms of how we rectify and really deal with the really deep-seated wounds of this country and racism that has existed. The Breathe Act, which again, that is an act that was drafted by folks with the Movement for Black Lives. How do we actually do this work of abolishing police and creating real public safety in our communities and addressing some of the economic trauma that has also been experienced in our communities. Being involved in the election cycle was clearly important. But again, I think it's going to be the continuation of the work of social movements like the Black Lives Matter movement, like the Poor People's Campaign, which I've done some work with, that are really going to get us to the kind of radical imagination, the radical restructuring that we all deserve, because this pandemic has shown us so clearly how racism operates to steal life, and to literally cause death. And if we go back to normal, then I fear that we've missed the entire lesson. And so this is the last part of that reflection that I wrote for the journal. I said, if our field is truly committed to preventing death, saving lives, and eliminating racial inequities, then we can no longer be content with the status quo. In this moment and beyond, we must rise, resist, and align ourselves with the communities and social movements demanding the kind of radical restructuring of society that we all deserve. Silence is no longer an option, and speaking truth to power is the only way forward. Justice demands it, and our collective lives depend on it. If 2020 has not convinced us of this, I fear nothing else will. So with that, I just want to say thank you for the time, and open to some questions and conversation.
Thank you so much, Dr. Barber, for that absolutely masterful presentation. I forgot to say at the beginning of the talk that one of our speakers, Dr. Marcella Nunez-Smith, was unable to join us today due to a personal emergency. However, I myself am very grateful for the extra time that we had with Dr. Barber. So as a center